Today we are going to discuss about the lumbosacral procedures, CM guided lumbosacral procedures. Next two modules will be on ultrasound guided periphery and ultrasound guided spine. Today will be CM guided basic lumbosacral procedures. We'll be concentrating on the lumbar and the sacral area. So before I'll be demonstrating the procedures on the mannequin. So first I'll be in this 3D anatomy. I'll be just showing the important structures, important target, where we are going to do, how we are going to do, how we are orienting our CM. So after this discussions, I'll be taking a short break to set up our mannequin and the CM, and then I'll be again starting the live demonstration. Okay. So if anybody wishes to share anything, you can, and then we'll be starting. I hope I am visible and my voice is audible, right?
Yes.
Hello?
Yes, audible.
So I am audible and I am visible, right?
Yes. Yes, sir. You're
Okay.
listening.
Okay. So today we'll be going with the lumbosacral procedures. And in this lumbosacral procedures, we'll be discussing about the facet joint, intra-articular, medial branch, because nowadays medial branch block is more important because we can get the long-term results with the radio frequency of the medial branch. Then we'll be going for the transforaminal and lumbar sympathetic, sacral nerve block, and your caudal epidural and sacroiliac joint injections. So these are the 6 procedures which we'll be demonstrating. And first I'll be showing you here in this 3D anatomy how to do that. And already I have shared the documents with you. And I hope you have gone through that document. If not, then tomorrow also you can go ahead with the documents. And obviously, you'll be also able to access the recorded lectures. So first, the lumbosacral areas, I'll be discussing about the facet joint. Let me enlarge it a little bit. So facet joint is what? Facet joint is the synovial joint on the either side, one on the right side, one on the left side at each segment in the lumbar. So this is your left-sided and that is your right-sided. So how the facet joint is formed? Facet joint is formed is, this is your superior, this part is your superior inferior articular process, and this is your superior articular process. So you see, superior articular process is concave and the inferior articular process is concave. That means it is not a single plane, and that is the reason why through the lumbar facet joint we cannot go through and through into the spinal canal because it's a curved block. So to go for the medial branch block, we need to place the needle here at the junction of the superior articular process, and this is the transverse process, superior articular process and transverse process here. And for the intra-articular, so in this facet joint, normally in the lower part, in this part, we try to go for the facet joint injections if we are going intra-articular. But as I told you, intra-articular facet joint is inferior than the medial branch block. Medial branch block is nowadays the having the long-term results, and that is more evidence compared to that of the intra-articular facet joint injection. So these are the 2 procedures what we'll be demonstrating. Remember it, how to orient the CM. So one thing you should remember that for all lumbosacral procedures, first step is true epiview. True epiview means the spinous process should be equidistant with the 2 pedicles. So 2 pedicles and spinous process should be equidistant in the AP image. CM should be, I'll be demonstrating about the CM as well. So that is the first step. Next step is making the end plate parallel. End plate means this is the end plate. So this end plate should be, you see, now this is not the end plate is parallel, but now this is the end plate is parallel. That means you should be making the craniocaudal tilt of the CM to make the end plate parallel. So first step is a true AP, second step is making the end plate parallel, and then third step is making it oblique. So when you are making an oblique, you'll be able to imagine a Scottish dog. Like you can see here is a Scottish dog you can imagine. So here, this is the ear of the Scottish dog, this is the nose of the Scottish dog, face of the Scottish dog, front leg of the Scottish dog, hind leg of the Scottish dog. So hind leg of the Scottish dog is my spinous process. Front leg of the Scottish dog is by the inferior articular process. Nose of the Scottish dog is by the transverse process. Ear of the Scottish dog is your superior articular process, and body of the Scottish dog is your lamina. So once you are making an oblique, then you are going to visualize or imagine a Scottish dog. Once you are getting that Scottish dog image, then we are ready for some procedures. What are those procedures? One procedure is intra-articular fascial joint injection. So you have to go for this anywhere, but ideally in the middle of the in the middle or the little below of this joint. So this is intra-articular. Then is your medial branch. Needle should be placed here at the junction of the superior articular process and the transverse process. At this junction, I should be placing the needle here. This is for the medial branch, because medial branch runs like this. Okay, let me put the nerve, and then we will be able to understand that how the nerves are basically. Where is the nerve? Okay, so they are the nerves. So you see the medial branch, this is the nerve root. So the nerve root, after it is coming out, so this is your ventral rami and this is your dorsal rami. So dorsal rami have this medial branch. You see, this is the medial branch. So this medial branch gives the two articular branch. One goes above facet joint, and one goes below facet joint. And another branch goes to supply the multifidus muscle. Multifidus muscle is here. So there are the three major branches of the medial branch. Medial branch is what? Medial branch is the branch of the dorsal rami. So dorsal rami have three branches. One is your lateral, another is your intermediate, another is your medial. Lateral branch supplies the longissimus muscle, medial the iliocostalis muscle. The intermediate branch supplies the longissimus muscle, and the medial branch supplies the multifidus muscle. Apart from that, medial branch, very important, is your facet joint. Facet joint. So if you wish to denervate one facet joint, you have to ablate two medial branch, one at the same level and another will be coming from above. So two medial branch block should be done. Where to be done? At this junction, at the junction of the superior articular process and the transverse process. At this junction, we have to place the needle here to block the medial branch. So this is one of the very important procedure, and facet joint pain is quite common. So we will be demonstrating that. So let me put it off. So now the other procedures what we will be demonstrating today is your, and very important procedure is your lumbar transforaminal epidural. So now to understand the transforaminal epidural, we must be knowing the anatomy of the foramen. So what is the anatomy of the foramen? So foramen is bounded, you see this is a neural foramen. Foramen is bounded above by, this is your one pedicle. This is your, if I can make it a little more lateral, you see this is foramen bounded by, this is the neural foramen. So bounded by one pedicle above, another pedicle below, and then posteriorly what? Posteriorly, this is your inferior articular process, this is your superior articular process, and anteriorly vertebral body, and lower part is by the disc. So this is your neural foramen. And what is there in the neural foramen? Exiting nerve root. Nerve root is exiting from here. Let me put again the nerves. So you see, exiting nerve root is coming from there, and this is the exiting nerve root. So there is a dural sheath there. So exiting nerve root there is the upper part of the foramen. Lower part of the foramen, we are having the loose areolar tissues and some of the blood vessels. Upper part of the foramen is very important because there is your exiting nerve root, and that is accompanied by the radicular blood vessels which is supplying the nerve root. So when we are going to inject into the transforaminal, along the nerve root, one of the very important things is your not to inject into the radicular blood vessel, because radicular blood vessel is very important. It is supplying the nerve root, and if you are there is a spasm, or if you are occluding it by particular steroid, then there might be infarction of the nerve root, which is very dangerous, and sometimes it might be going inside also. So that is your transforaminal epidural. Now transforaminal epidural can be done in the two upper part. Here upper part of the foramen. So this is one pedicle, subpedicular or suprapedicular. This is the pedicle. Above that, you can go ahead with the here or here. So the two approach. Upper part is called safe triangle approach, though it is not safe, because why? Because the this, if we are doing like this, you see the upper part of the foramen, the nerve root is there in the upper part of the foramen. If I come in the lower part of the foramen, lower part of the foramen is what? We are having the dorsal rami and these things, but otherwise, lower part don't have very important blood vessels, don't have the main nerve root. Upper part is having the main nerve root, which is more dangerous than the lower part. That is the reason why nowadays we prefer to go into the epidural, this transforaminal epidural through the lower part of the foramen, so that we are not damaging the exiting nerve root, as well as we are not going to damage or hit the blood vessel which is supplying the nerve root, radicular blood vessels. So lower part is known as Cambine's triangle approach. So I'll be showing you how to do that procedure into the mannequin. I'll be demonstrating it. But remember, the upper part is nowadays less commonly done. Earlier, when we started our career, that time we learned only the upper part of the foramen. Transforaminal epidural that time means the upper part of the foramen or subpedicular approach. But nowadays the days has changed. Nowadays we prefer to go into the lower part of the foramen because it is safer. So these are things what we'll be demonstrating today. So after that, what else will be demonstrating is the lumbar sympathetic. Lumbar sympathetic is where lumbar sympathetic chain is there in the anterolateral border, anterolateral border lumbar sympathetic chain. So again, let me put the lumbar sympathetic chain. So though there is a lot of nerves, but still this is the lumbar sympathetic chain, this one. So this is these are the ganglions. So this is situated in the anterior, anterior lateral border. So this is the lumbar sympathetic chain. So anterolateral border. So what we need to do is how we are going to do the procedure. First procedures, remember this is the true for all the lumbar procedures. First step is true epi image. How to get a true epi image? Spinous process will be equal distance from the two pedicle. Next step is making the end plate parallel. By how? By craniocaudal tilt. Then is your oblique. So how much oblique? Till we imagine a very good Scottish dog, and also during the lumbar sympathetic, this spinous process should be just in line with the lateral border of the vertebral body, and in that you just go by the tunnel vision. You just go there and reach there in the anterolateral border, and then check by the lateral view and see that your needle is just posterior to the anterior border of the vertebral body. So this is how the lumbar sympathetic is done. And then in the sacral area, we'll be going for the few procedures. One is your sacral foramina. So the sacral foramina SOR nerve root. So again, remember that we are having the two foramina. Nerve root here is dividing into ventral rami, dorsal rami, like the lumbar nerve root as well. But here, for the ventral rami, we are having the ventral foramina. You see, this is the ventral foramina, the ventral nerve rami is coming out. And through the dorsal foramina, the dorsal rami is coming out. Dorsal rami is very thin, so the dorsal foramen is also smaller than the ventral foramina. But again, in an epi view, we will not be able to understand which one is dorsal, which one is ventral. So for that, what we need, that we need to make a craniocaudal tilt to align this ventral and dorsal, See, if we are making the craniocaudal tilt, we'll be able to align the ventral and dorsal foramina, and then you go through the foramina and you reach to up to the anterior border of the vertebral body, so that your target is ventral rami, because radicular pain which is going down is the ventral rami. Dorsal rami is supplying the back, only the multifidus muscle and some other small muscles. So dorsal rami is not our target for the nerve root block. Nerve root block, our target is ventral rami, because that is having the major supply. The leg supply is by the ventral rami, not the dorsal rami. So through the dorsal rami, we'll be going anteriorly and we'll be going up into the ventral rami, and there you have to give the injection. So this is the sacral nerve root. Particularly the S1 nerve root is very important for the L5 S1 disc prolapse. S1 nerve root is very commonly involved. Then we'll be going for the sacroiliac joint injection. So again, you see sacroiliac joint, this is your iliac crest, and this part of the joint, you see, this part of the joint is our target. So this part is your synovial part, and this part is your fibrous part. Upper part is fibrous part, lower part is synovial part. So for that, what we have to do, you see, I have to go contralateral oblique from the other side, because then only we can, if I'm going like this, we are going to hit the iliac crest. So we cannot go by the ipsilateral oblique like the lumbar procedures. So here we have to go contralateral oblique. You have to come from the other side to enter into the sacroiliac joint. So for the sacroiliac joint, we have to make a contralateral oblique view. So this will be the sacroiliac joint. Then the caudal epidural, all of you are doing, but CM guided caudal epidural is important that we have to place it, and see the dye. So CM guided caudal epidural is little different what we are doing in the anesthesia practice. So in the here, what you have to do? First, you have to identify the hiatus. So when you are identifying the hiatus, we are putting a needle there, and then we are checking the lateral view. In the lateral view, we'll be seeing the sacral canal, and we'll be going inside. This is for the sacral, the caudal epidural injection. So these are the things what I'll be demonstrating today, and I'll be taking a short break before I am going for the demonstrations to shed the CM and Mannequin. But if still you are having any questions regarding the procedures what I'll be demonstrating, so you can ask me. Few of the procedures is little advanced procedures like the superior hypogastric and the other. This I am not demonstrating today. So I'll be demonstrating the procedures, lumbosacral procedures, which are very basic procedures, which I'll be demonstrating today. So any questions if you are having, you can ask me. No questions?
Sir, good evening, Dr. Jiten Agrawal.
Yes, yes.
Sir, good evening.
Yes, good evening.
Sir, I am Dr. Jiten Agrawal here, long time back.
Yes, yes. Tell.
Sir, one question I just want to ask. While we are blocking the medial branch.
Yes.
Hello.
Yes, tell.
So, is there chances of?
Pardon?
I am audible, sir.
Yes, you are audible. Tell.
Am I audible?
Yes, you are audible.
When we are blocking the medial branch, there are chances of blocking of the intermediate and lateral branch also.
Huh?
There will be the chances of blocking of intermediate and lateral branch also.
Yes, there is every chance that particularly if you are doing the local anesthetic and steroid, you have every chance that you are also blocking the lateral and the medial branch. But when you are doing the radio frequency, what we do, we stimulate it and we see whether the multifidus is getting contracted or not. And if your needle is very close to the junction of the supraarticular process and the transverse process, then chances of doing the lateral branch is very rare. Intermediate is close, so we can go for the intermediate branch block inadvertently. That is always a chance.
Okay, thank you. Thank you.
Yeah. Okay, I forgot to mention another thing. Celiac plexus block. I know many of you have had the interest in the celiac plexus block. Celiac plexus also I'll be demonstrating. So celiac plexus block, what we'll be doing? You see, celiac plexus is situated at the level of the L1. In front of the L1 vertebral body, there is a aorta, and from the aorta we are having the celiac trunk. So we have to reach there in front of the aorta, and you can do it under the CM guidance or you can do under the ultrasound guidance. So CM guidance technique, the classical technique is your Capis technique. So Capis technique is what? Capis technique originally was by originally it was blind technique, but later on it was modified. So in the Capis technique, what was done? So a triangle was drawn, 12th rib on the either side and the L1 vertebral body. So the line is drawn, and at this junction where it is crossing, let me draw it. So one line is like this, another line is like this, and another line is like this. So when this line is drawn, so this is the needle entry point on the either side. So initially you go and hit the L1 vertebral body there, and then you increase the angle to go anterior to the L1 vertebral body. This is the original Capis technique. But there, it is not the trans-aortic approach. Trans-aortic approach, if you are going through and through the aorta, then success rate is much better. And we first published one important technique, how to do it in a journal of pain in 2009. And that is one of the very common technique of doing the trans-aortic epidural, not only in India, in many parts of the world. So how we are doing it? So first, let me erase this drawing. Okay, so what we'll be doing? So there, we will be first taking this epiview, and then we'll be making it oblique. How much oblique? till this transverse process is within the vertebral body, this much transverse process. And then we'll be imagining a triangle. You know how this triangle is formed? So this triangle is formed one side by the vertebral body, another side by the the 12th rib, and draw an imaginary line at the lower border of the L1. So this is the triangle. What happened? What's the incident? Okay, sorry. So the triangle was bounded one side by the 12th rib, another side by the vertebral body, and base is open. You imagine a line there. So this triangle, if the middle of the triangle by a tunnel vision, coaxial view, if you are going directly, then you are always going to hit the aorta. So this was our hypothesis based on studying different CT scan report. And then you go through and through the aorta, go enter to the aorta. Enter to the aorta is your celiac trunk, and around the celiac trunk is having the celiac plexus, and you do go for procedure. So I'll be sharing one video and where live case video. Today also I'll be showing you the procedure in the Mannequin, and you'll be able to understand how to go ahead with that. So up to this much for here in the 3D anatomy. If any one of you wish to ask anything in this 3D anatomy, wish to see anything, I can show you. Otherwise, I'll be going with the Mannequin practice. Give me 5 to 7 minutes break to prepare the Mannequin. So do you have any other questions regarding the 3D anatomy? No? Okay, so I'm taking, what is the time right now? 6:23. So we'll be meeting at 6:30 sharp. We are ready with these things. We are having 2 camera on, and this is our Mannequin. This is the caudal end, this is the cranial end, and you can see this is the CM. And on the left hand side, we are having the CM image. So what I'll be doing? I'll be doing the procedure there, and the live you can see on the CM X-rays as well. So as I told you, so for all lumbosacral procedures, the first step is what? First step is to have a true AP image. So what is the meaning of the true AP image? As I told earlier, that the true AP image means that the 2 pedicle, so this is one pedicle, this is one pedicle, this is the spinous process. So these 2 distance will be equal. That means that is a true AP image. So first step is to have a true AP image. Clear? The next step is what? Next step is make the end plate parallel. End plate parallel means, or also called squaring. That means here you see it is one line, but here you see this is not a one line. So that means here we are ready to do the procedure here. So this is looking like a square. So this is called squaring of the vertebral body. So you can do the procedure here, you can do the procedure here, but not at this level, not at here, not at here. I can do procedure here, I can do the procedure here. So this is called squaring. So first step is true AP, next step is squaring. And then what? Then I'll be making it oblique ipsilateral. If I used to do the procedure on the right side, okay, one thing I forgot to mention, that here our right side will be corresponding to the right side of the image, left side will be corresponding to the left side of the image, CR image. And initially you have to check it. You put a radiographic marker to see that whether you are in the right, which one is right side, which one is left side. So conventionally, you'll be always standing on the left hand side of the patient. Head side is this one. So you'll be always standing on the left side of the patient. CR will be always on the right side of the patient. And on the screen, the left is patient's left. Screen's right side of the image, X-ray image will be the right side. So these are the basic steps. And then what? I have to make a true AP. True AP means that pedicle and the spinous process will be equal distance. And then you have to make a craniocaudal tilt to make the end plate parallel. After that, we are making it oblique. So oblique. How much oblique? Till the facet joint is opening up nicely, or you are able to appreciate a very nice Scottish dog. You see, now we can appreciate a very nice Scottish dog in the image I was talking. So you can see this is the the head of the Scottish dog, this is the ear of the Scottish dog, nose of the Scottish dog, neck of the Scottish dog, front leg. Front leg is by what? Inferior articular process. Hind leg, then your body by the lamina, tail by the other side, your the transverse process. So this is your Scottish dog. Once you are getting the Scottish dog image, then you are ready for few procedures. What are those procedures? One is intra-articular facet joint. So here or here, you put the needle in the intra-articular facet joint, or you can do the medial branch. For the medial branch, it should be the eye of the Scottish dog, internal vision here or here. Then we can go for the transforaminal. As I told you, foramen is from where? One pedicle to another pedicle is your foramen. That means from here to here whole is your foramen. Now, if you are going into the upper part of the foramen here, then this is known as subpedicular approach, or the supraneural. Nerve is like this. This is the nerve root which is exiting. So this is the supraneural approach. And or other second approaches, you can come here. Then this is called the intraneural approach. This is called subpedicular approach, and this is known as the suprapedicular approach. Supraneural or subpedicular, that means the space between the pedicle and the nerve root is your, in the upper part is your supraneural or subpedicular, and between the nerve and the pedicle, that is your the intraneural, but this space is little larger than this space. So this space is safer than this, though conventionally this is called like the safe triangle approach. So what is the safe triangle? Again, it is not safe, it is unsafe, but still it is called safe triangle. So this is the nerve root. So if you have one side is nerve root, another side is this transverse process, another side is vertebral body. So this triangle is safe triangle approach. And another triangle you can imagine, one is your facet joint. So this is another triangle. So this triangle is known as the Cambine's triangle. Cambine was the neurosurgeon. By his name, this triangle is named as Cambine's triangle approach. So what we'll do, we'll put one needle here in the eye of the Scottish dog for the medial branch, one here, intra-articular facet joint, one here for the transforaminal epidural, supraneural approach or subpedicular approach, another here for the infraneural or suprapedicular approach. And if we are advancing this little further, we are going into the disc. So the discography procedure is basically the Cambine's triangle approach is for the discography procedure as well. If we are putting the needle further, we are going into the disc. So first, I'll be putting this 5 needle, and then I'll be going with the other procedures. So this 5 needle, one is intra-articular, one is medial branch, one is transforaminal here and here. Okay?
Sir,
Yes.
sir, I have a question.
Yes.
Sir, you said that if we are going for the ipsilateral approach, then for the right side, we have to change our position to the right.
Yes. That means this is the right side of the image, So
Yes, sir.
this is the patient's right side as well, this side. This side will be
Then
corresponding
we,
to this side. If not, then
yeah,
you ask the radiographer to flip the horizontal flipping.
okay. And then the procedure will be done from the right side.
No, I'm standing on the left side. You should be,
Yes.
whether you are doing procedure on the right or left, you will be always standing on the patient's left side. And CR will be
Okay.
always on the patient's right side. Whether you are
Okay.
doing the right-sided procedure or left-sided, it's not like surgery. When you are doing the surgery on the right side, you are standing on that side, left side. No, not like that. So in interventional procedure, you'll be always standing on the left side of the procedure, CR on the right side of the procedure, and then whether you are doing right-sided procedure or left-sided procedure, you'll be doing it from the left side only. That is the conventional way. Okay?
Okay. Okay. Yes, sir.
Okay. So now we are ready for some procedures. Let us start doing the procedures. And we will be doing it a tunnel vision. What is the tunnel vision? Tunnel vision, or also known as the coaxial view, means this needle, if the CRM is coming like that, I'll be seeing it as a line. But if this needle, the CRM is coming like this, I'll be seeing as a dot. So the dot, that is known as coaxial view. That means I'll be seeing this needle not as a line. I'll be seeing this needle as a dot. That means CRM will be coming in line with this needle. Then it is called coaxial view. Okay, so how much degree, how much from midline? Don't measure anything. You have to have this image, Scottish dog image. Then you are ready for the procedures. Okay, first intra-articular facet joint injection. Picture. So where I am doing the procedure, depending on my C-arm image. I'm not measuring anything from how much away from the midline or something like that. Okay. So what I'm trying to do is in tunnel vision, I'm trying to go into the middle or the inferior part of the facet joint. Okay. Now I am tunnel vision. I am into the joint. Okay. You'll be getting a pop when you are puncturing the capsule of the joint. So this is one needle. I'll have to check it by the lateral view, but first I'm putting all the needles and then I'll putting on the lateral view. When you are doing the procedures, don't do all the procedures together. Normally, it's not also required to do all the procedures together. But for the, the sake of saving time, I'm doing like that. Picture. So now the next procedure, what I am trying to do is your medial branch. Medial branch block is where the junction here. Picture again. Junction of the superior articular process and the transverse process, also known as the eye of the Scottish dog. Again, in tunnel vision, I'll be hitting the bone there. Picture. In tunnel vision, I'll be hitting the bone there. Picture. Okay. So this is again in tunnel vision, coaxial view. I'm hitting bone there. This is for the medial branch. Then another needle I'll be putting for the subpedicular approach. Picture. Picture. This needle is for the subpedicular, the supraneural approach. Picture. In tunnel vision. Okay. Now it's perfect tunnel vision. I'm hitting the inferior border of the pedicle, and now I'll be slipping it into the foramen. And the fourth needle I'll be putting in the lower part of the foramen. Picture. Just lateral to the superior articular process. Picture. Just lateral to the superior articular process. In tunnel vision again. In tunnel vision. Upper part of the pedicle. Okay. Now I'll be checking by the lateral view because this is a 2D image and actually patient is 3D. So you have to check it by the different angle and then only you will be able to confirm that you are in the right position or not. So in the lateral view, you see, this is your first needle is your interarticular facet joint. Picture. As I told you, we can't reach through and through the needle, you'll be getting only the upper part of the foramen. The second one is over the transverse process. You see, this is the transverse process. This is your transverse process. And needle is just over the transverse process. I told you it will be the junction of the transverse process and the superior articular process. The third needle is, you see, this is the foramen. And this foramen, you should be needle should be in the posterior just most part. Don't advance the needle because here is your nerve root and here is your radicular blood vessels. So if you are advancing the needle further, what will happen? We are going to puncture the nerve root. Patient will be jumping, kicking you. And also there is a risk that you are puncturing this radicular blood vessel, which is very dangerous. The lower needle, I have to advance a little more. Picture. Okay, so this is the perfect one. Lower part is this relatively safer part. And you see, if I am advancing the needle little more and going little above, then I am going to the disc. Picture. 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 Okay, so I'm entering into the disc. So that means the Cambine's triangle approach, if we are advancing the needle further, that is also for the discography procedure. If you wish to do any disc procedure, endoscopic discectomy and other disc procedures. So this is how we have to go. That means you have to go into the inferior part of the foramen. So you see, this is the whole of this neural foramen bounded by one pedicle above. This is one pedicle. This is another pedicle. So your upper part is occupied by the nerve root. Here is the nerve root and radicular blood vessels. Lower part, you have to come to the lower part. This is known as transforaminal approach, transforaminal discography approach. And also, if you're doing the endoscopic discectomy, through the same track, we go for the transforaminal endoscopic discectomy. The same way. First, the guide wire has to be placed in the same person like what I did right now. So these are the 4 procedures I have shown you. Now I have to check by the epi view as well. Epi. Okay. So all the needles are in the perfect position. First needle is in the facet joint. Second needle is in the, the junction of the superior articular process and the transverse process for the medial branch block. Third needle is for the, the transforaminal through the supraneural approach. And last needle is inside the disc. Last needle has gone into the disc through the foramen into the disc. So these are the 4 needle placement. So if you're having any questions regarding these 4 procedures, you can ask me. Then I'll be going ahead with some more procedures. Do you have any questions regarding these 4 procedures? Facet joint interarticular, facet joint medial branch, transforaminal, and discography.
Hello, sir.
Yes.
I wanted to ask you that do you bend the tip of the needle too, or you
Yes,
don't?
yes. But tip of the needle, you bend it. That will be helpful for steering the needle. If you used to go the right and the left, you just turn the bend side towards that and will be easily going to that side. Okay.
Okay, sir. So it is safer to have a tip bended, sir.
Yes, we'll normally bend the tip a little bit. That will be easy to steer the needle to your desired area.
Oh, okay, sir.
Excuse me, sir. When you
Yes.
aim for the Scotty dog position, the tip of the spinous process should be within the body or can go beyond the body.
I didn't understand your question. Can
So
you repeat?
when you are making a Scotty dog position,
Yes, let us make a Scotty dog position. Oblique. Okay, so this is the Scottish dog position. It
the
will
tip of tip of the spinous process of ipsilateral side
tip
should
of the
remain
spinous
within the
process of
body.
the ipsilateral side means spinous process is only one. So here is the spinous
No,
process.
sorry, transverse process. Sorry, transverse process.
Transverse process is here.
Yes, the tip can go beyond the body, or it should remain within the body.
If you are doing the lumbar sympathetic, then it should be within the vertebral body. But if you are doing these 4 procedures, here the tip might be, little bit of protruding. That is not an issue.
Okay,
But for the lumbar sympathetic, because lumbar sympathetic, I have to go there, no? So that is the reason why I'll be showing the right lumbar sympathetic right now. So there you have to make it more oblique so that the transverse process, tip of the transverse process is within the vertebral body.
Yes, thank you.
Any other
Sir, one more question I want to ask, sir.
Yes.
Sometimes some in disc herniation cases for the unilateral disc, single disc only, should we go, what type of block should we do, or should we refer to the spine surgeon?
Okay, we'll be discussing. We will be discussing that. We just learn the procedures. Right now, we are concentrating on the procedures. All other questions, we are having the separate time for that. So single level disc herniation is, there are lots of different types of disc herniation. So if there is a motor deficit, then you have to refer this for the surgeon, or you yourself can do the endoscopic discectomy. So there the surgical discectomy to be done. If there is no motor deficits, then you can go ahead with the transforaminal epidural, what we have shown right now. Okay.
Okay, sir. Thank you, sir.
Having more discussion on this on the last day. Right
Okay,
now, learn the procedures.
thank you, sir.
Any other questions regarding the procedures? Okay, now I will go for the lumbar sympathetic. So lumbar sympathetic was what? We have to make it little more oblique. How much? Till the transverse process is picture is within. Somebody who asked me the question, the transverse process. You see now the transverse process within the vertebral body. So now we are ready for the lumbar sympathetic procedure. So my needle will be here, or for this is for the L2. Or sorry, the L2 is here. So here I should put in the needle. If it is L3, then upper part. So, but more or less the procedure is similar. So what I'll do, you have to take a longer needle for the lumbar sympathetic. So picture. Okay, so that is my needle end point. And in the tunnel vision, I'll go. And I'll be touching the vertebral body there. And I'll be going with lateral view now. In the lateral view, my needle should be just posterior, just touching the anterior border of the vertebral body. Okay, so I'll be advancing the needle further. Picture. Picture. Okay, so that is the end point. So my needle is, this is the vertebral body, anterior border of the vertebral body. So my needle will be just touching there or just posterior to that is your on the lateral view. And for the L2, my needle will be upper 2/3 and lower 1/3 junction. For the L3, it should be opposite, upper 1/3, lower 2/3. So normally L2, L3 is always done. Sometimes L4 is also done. For the L4, you can put the needle anywhere. But for the L2, it should be upper 2/3 and lower 1/3 junction. For the L3, upper 1/3 and lower 2/3 junction. And by the AP view, my needle should be just crossing the lateral border. Again, check by the AP view. That is your, this is just, arithmetic oblique. It should be crossing the lateral border of the vertebral body. So that is your lumbar sympathetic. So now here the needle has been placed little more, but that is okay because you are there in the lateral view by the anterior border of the vertebral body. Now I'll be changing. No, okay. I have to go for the lumbar sympathetic, the caudal epidural and the transforaminal and the SI joint. Sacral procedures now. Any questions regarding the lumbar sympathetic? So lumbar sympathetic is also similar procedure, almost similar procedure. Only thing is you are advancing the needle more and you are going to the anterior border of the vertebral body. Okay, now you see there are sacral foraminas, So lots of foraminas are there. So you don't know which one is ventral, which one is dorsal. So what you need to do? You make a cranial tilt. Why cranial tilt? Because sacrum is not like this. Sacrum is like this. So you have to make a cranial tilt like this. And then you see picture. Then you see Arektu. Then you see what is happening. See this part of the foramen, ventral foramen and dorsal foramen is aligned. So that will be my entry point. So I'll be entering through that foramen and I'll be going into the where? As I told you, entering through the dorsal foramina and going into the
ventral foramen.
Pictures. Again by tunnel vision, picture. Tunnel vision means I'll be seeing it as a dot. And it will be seen as a dot, not as a line. Okay, I'll be checking by the lateral view now. Okay, so I'm into the ventral foramina. I'll be going enter little more, tail little more picture. So you see, what are the important landmark here? So ektu payal dikhane dise. What are the important landmark? You see, this is your fused lamina. For the sacrum, the laminas are fused. So this is the sacral lamina. Vertebral body is from here till here. Again, the fused vertebral body. So this is your S1, this is your S2, and this is your sacral canal. White area is your sacral canal. Okay, I'm just erasing it again. So that means where is your ventral foramina and where is dorsal foramina? Ventral foramina is here where I have entered and dorsal foramina is here. So this is, so your needle is, we are going, you see if I'm pushing it, I'll be going through and through. Picture. See? So, but not up to there I'll be going. Picture. It should be here, just posterior to the anterior border of the vertebral body. So stay there. But what is very important to what I am trying to emphasize, don't, just keep the needle here. Don't keep the needle here. Why? because then you are going to block the dorsal rami. Dorsal rami is not your target. Dorsal rami is supplying only what? The multifidus muscle there. So that is not our target. Our target is ventral rami. Ventral rami is going towards your leg, towards your shoulder, towards your lateral aspect of the foot. So that is my target. So I have to go into the ventral foramina. Okay, clear to everybody? Now I'll be going into the sacroiliac joint. Okay, I might be going faster, but I have already shared the literature. So you just go through the literature. You just
for
see
S1 we have to for S1 sir, just we have to reach our needle till the ventral foramina,
ventral foramina.
or we have to go inside.
You have to go into the ventral foramina. Needle should not be coming out anteriorly. I told you that is not the position. I told just posterior to the anterior border of the vertebral body. Okay. Okay. So those who are new, go through this recorded video again and again, and I'll be sharing some other videos where the live procedures are done. I'll be sharing over 4 or 5 important videos. So go through those videos as well, but go through the recorded videos first, and then try to grasp the procedure. Okay. So now
Sir,
yes.
when we are passing from the dorsal foramen to ventral foramen, there are so many structures. Can we injure them?
Like, what are the other structures there?
Nerves, sacral plexus.
Nerve is more central, Nerve is more central. The cauda fibers are central. So when you are going, nerve root comes like this. So if you are going here, there is no neural structures there. Okay. So what is important there? But it is rich in the blood vessels. It is very common that you are puncturing from the blood vessels. If you are puncturing the blood vessels, then you make sure that how to know that you are in the blood vessel? Sometimes the blood will not come. So you have to give the dye and see whether the dye is vanishing. If the dye is vanishing, means you are in the blood vessels. So that is how you have to understand. But neural structure in the midline, not into the foramen area. In the foramen, only that nerve root will be coming, which is exiting to that foramen. No other nerve root. Okay? Okay. Any other question? I feel very happy if somebody is asking like this question, because I can understand they are into the subject, they are into the topic. And if you are not asking the question, I really in dark whether you are understanding or not. Okay. So try to make this session very live, asking lots of questions. If you are asking lots of questions, I'll be very happy. Okay.
Sir, in this case also we have to bend that needle tip when you are entering
Bending
the
the needle
foramen.
tip is your choice, as I told you. Any interventional procedure, bending the needle helps in steering your procedure. So if you wish to go to the right, left, above, below, if you are bending the needle, it makes this thing easier. What you have to do? You need to bend side towards your target side. Turn the
Sir,
side
please show one.
towards you. It will be easy to steer the needle.
Okay,
Sir,
sir.
please show one bend needle.
Bend needle?
In zoom.
Okay.
Yes, sir.
Okay. See? Can you see? Bend needle should not be very large bend, It should be something around, how much should I say? Around 3 to 5 degree, not more than that. Okay? This needle is little more bend. You see this here? Can you see here?
Sir, it cannot be appreciated well.
Not much.
Yes, sir. Yes, sir. Now.
Okay. So, okay, let me go to the sacroiliac joint. Sacroiliac joint, you see, as I told you in the 3D image, that a few structure you have to identify. One is your iliac crest. This is iliac crest. Next is this is a very prominent joint. This is the anterior border of the sacroiliac joint. And another very faint border, you can see this is a posterior border of the sacroiliac joint. That means this part between the posterior border, this is a fibrous part. Upper, superior, and the posterior part is a fibrous part. You cannot enter into that part of the joint. But this part is your synovial part. So your target is the inferior part. But what you have to do is align this joint and this joint. How to align these two joint line? By making an ipsilateral oblique. Contralateral oblique. If you wish to do the procedure on this side, make it oblique towards the other side, so that your two joint line will be merging. You see what is happening? একটু oblique কর একটু You see the two joint line has merged.
Yes. You see, now this two joint line has completely merged this part. So initially we could see the medial border and the lateral border of the sacroiliac joint. Now medial and lateral border has been merged together. And now this is my target. I cannot reach here, this part. Why? Because this is covered by this iliac crest. So my target will be here. That is the inferior most part of the sacroiliac joint. Everybody understood it?
Yes,
Sir,
sir.
will you show, sir, will you show
Let
us
me again
the
go, let me start
position
again
of
with
this
the AP.
yarn?
You just see that what is there in the AP view. This is a true AP view. Are you sure? Are you sure? All right. Bas, take it. You see now, you can see the three joint line, you understand. This is one is the iliac crest. Then this is your posterior joint line. This is
Yes,
your
sir.
anterior joint line, anterior border. So you have to merge
Yes.
these and these together. How? By making a contralateral oblique, opposite side oblique. This is the right side joint, so I'll be making it opposite side
Mm.
joint. And in that way, I'll be merging these two joint line together. So you see, if I'm making contralateral rectum, if I'm making a contralateral oblique, then I'm basically merging the two. See now, this joint line is completely merged. Can you appreciate now? So now
Yes, sir.
this part of your joint, this part of your joint is your target. So I am again going by the tunnel vision. Picture. Picture. So that is my picture. That is my needle entry part. Again by tunnel vision. Picture. Okay, now I'll be going by the lateral view. I'm into the joint now. Okay, so I will be withdrawing a little bit. I have gone a little more. Picture. Okay, so this is the final position for this joint. So this is your sacroiliac joint ejection. Clear?
Yes, sir.
Joint here.
So in lateral view, can you show the joint line when we put the die?
Joint line is actually little anterior. Up to here is a joint line. It's like a pinna of the ear. Lower part is little like this.
Okay.
Okay. This is the anterior part of the sacral vertebral body. But joint line is here. Joint line is little anterior to the vertebral body. But if you keep the needle at this joint line only. Here, if you put the at this junction. Here it
Inferior
could be.
border.
Okay, sir. Thank you.
Okay, so now caudal epidural. So in the caudal epidural, first you have to identify the sacral hiatus. Here there is no coccyx bone here. So this is made up of original bone, but coccyx bone is not there. So you can understand, this is your cornu, this is your cornu, this is your sacral hiatus. So what I'll do, I'll be putting needle in the lower part of the S5 here, and then I'll be going into the lateral. Sure. Okay, now we'll be going lateral view. Okay, so I'm into the hiatus, into the sacral canal. check by the epidural. And advance further. How much I should be advancing? Between the S3 and S2 junction. You know, because the lower border of the S3, S2 is the till where the dura extends. So you should be at the junction of the S. I can advance the needle a little more. Picture. So this is your S2, S3 junction area. So now this much. Don't advance the needle further because then there is a very high chance of puncturing the dura. So advance the needle there and then give it a dye. The dye should be spreading. It's an inverted Christmas tree through the foramens. And then you go ahead with the procedures. I'll be again sharing all those videos in the live procedures, how it looks when you're injecting the dye. This is your caudal epidural. Right? Everybody understood it? Now the last procedure. The celiac plexus block. Picture. So first is you identify the area of the T12 and the L1. Okay, so you can see the T12 and L1, and then what you have to do is make a true epi. So it's a true epi. True epi, why? Because this is your equidistance, but here you see this is end plate is not parallel. So second step is true epi. Second step is making end plate parallel. For that I have to make a cranial tilt, caudal tilt. Sorry. For the remember the upper lumbar, you have to make a cranial tilt. For the lower lumbar, you have to make a caudal tilt. So you see now the end plate is parallel. And now what I'll do, I'll making it ipsilateral oblique. How much? Till this transverse process is within the vertebral body. Okay. Right bottom. Okay, now the transverse process is buried inside. So now I have to imagine a triangle there. Triangle is bounded by this line, medially by the vertebral bodies, and then we extend it. And here, if I am putting the needle there, in tunnel vision, I'll be going through and through the aorta. This was our hypothesis. We published it. I'll be showing this literature with you. So, and then I'll be going there, but we have to go further anterior. In the lumbar sympathetic, what we did, we were stopping at the anterior border, but here we'll be going beyond the anterior border, at least 2 centimeter in front. And here we'll be taking your a 15 centimeter needle. So my needle entry point is picture. So this is my needle entry point. Picture. This is my needle entry point at the center of this triangle in tunnel vision. Okay, now I'm perfect. So I'll be going like this. And then I'll be checking by the frequently I have to check by the lateral view as well. So here you see we are away from the vertebral body. We are not touching the vertebral body. So that is making the procedure painless. It is not going to touch it. So it will be very mild or almost no pain. Okay, so what I'll do, I'll be going further. Picture. Normally we encounter the aorta here. And then once you are encountered the aorta, you remove the stellate, you'll see the blood is coming. And if you're injecting the dye will be vanishing, going distally. And then you have to again put it further to go anterior. So normally around 2 to 4 centimeter in front of the vertebral body will be your needle position. Epi. And now we check by the AP. In the AP, it should be crossing the lateral border significantly. It should be almost towards the midline. Almost towards the midline, but in the AP view. So this is my final needle position. Again, you have to give the dye. Then you will be, seeing the dye is dancing because you are through and through the anterior border, and you'll be seeing the, the celiac trunk also pulsating. In the AP view, celiac trunk will be pulsating like this because the AP view celiac trunk will be cross section, a circular, which will be basically expanding and constricting. So also you'll be seeing the mesenteric artery also. That is also coming anteriorly. That will be also constricting it. So I'll be showing you the one live procedure video with you. So you go through that video about how to go ahead with the procedure. But this is the basic things what you have to understand. But again, transaortic approach is contraindicated if there is an aortic aneurysm, if there is a aortic calcification, or if there is a coagulopathy. Coagulopathy is contraindicated for any interventional procedures. But the aortic aneurysm and the calcific aorta. So how to know that? Just put an ultrasound probe and see if there is a dilatation of the aorta or if there is a calcification. If it is there, so this procedure is not suitable. In that situation, you have to go ahead with the Capiz approach. I'll be showing you the Capiz approach now. So in the Capiz approach, what you have to do? We have to draw the triangle, So as I told you, triangle, one side by the vertebral body, another side by the another. Okay, so picture. So one like this, one line should be drawn like that, another line will be drawn like this. So Capiz approach is bilateral, bilateral. One from the, one from the right, one from the left. Because we are not crossing the, the aorta. So we are far away from the aorta. Picture. So here the ribs are not nicely aligned, This is a mannequin. The right-sided ribs are not nicely aligned. Anyway, so this is how. And another line to be drawn where? Another line to be drawn at the AL1 spinous process. Picture. So where is my needle entry point? My needle entry point is lumbar needle action. So my needle entry point will be here at this point, at the junction of the angle, and then I'll it is a non-tunnel vision procedure. So what I am doing, first I'm trying to hit the vertebral body of the L1. Picture. So I'm hitting the vertebral body of the L1 here, and then you increase the angle. Picture. Increase the angle and go ahead. So here you'll be scratching it. This procedure is little difficult, as I told you, and I'm scratching the vertebral body. I'm going anterior, and now I'll be going lateral. Okay, so by scratching the lateral border, I'll be going up to the anterior border. This much. So this much, two needle, one from the left, another from the right. So here we are not going through the aorta. Here we are just going anterior. And this is also called the antecaudal approach. Why? Because your crura of the diaphragm is here, like this. So you are crossing the crura. That's why it is known as the antecaudal. So one side but here the two needle, and here the volume of the alcohol will be higher, 20 to 25 ml on either side. So around 40 to 50 ml on the either side. But for the transaortic, only single needle is enough, and 15 to 20 ml is enough. So because we are bang on target, we are just around the celiac trunk, and that is the reason why the volume of the drug should be less. Okay, so this much for today. If you are having any question, you can ask me.
Well, I have a question.
Yes.
sir, when we are going through the trans-abdominal aorta approach, then how can we be sure that whether we have punctured the aorta or the SMA, superior mesenteric artery?
Because superior mesenteric artery is anterior to the aorta, it is the anterior branch.
Yes.
So first
Yes,
you have
sir.
to puncture the aorta, then only you are going through the superior artery. Not
Yes,
superior
after
mesenteric,
we
you
have,
can puncture the celiac trunk as well. That is a possibility. But unless you are puncturing the aorta, you cannot reach the superior artery, superior mesenteric. And not only that, you will be giving dye. Dye will be delineating your aorta and the superior mesenteric artery. You can see all the artery because all the these arteries. I'll be sharing you.
okay.
And then you
Okay,
can
okay,
understand all the arteries, aorta, superior mesenteric, celiac, all the arteries will be visible there.
Okay, sir.
Which gives better pain relief, celiac plexus block or splanchnic nerve block?
Splanchnic nerve block is difficult. You know why? Because it is a very compact area. And you have to do only the radio frequency. You cannot do the alcohol injection. Celiac block is little easier because here your target area is big. You can give a large volume of the alcohol and you'll be... So success rate with the celiac plexus is higher than the splanchnic nerve block. And that means if the patient is having the cancer pain, where only disadvantage of the celiac plexus is the duration of the pain relief is less because alcohol gives around 4 to 6 months. And splanchnic nerve radio frequency, it will be giving the pain relief of around 1.5 years. So if the patient is suffering from the benign conditions, we prefer the splanchnic nerve radio frequency. But if the patient is having the cancerous conditions, CA pancreas, then the celiac plexus block with the alcohol is preferred. Understood?
Thank you, sir. Thank you.
But,
Thank you.
but
thank you.
actually, splanchnic nerve is forming the celiac plexus, isn't it? That means the
Yes.
indications are all same. It is the upper abdominal pain. But for the benign conditions like the chronic pancreatitis, calcific pancreatitis, we prefer to do the radio frequency of the splanchnic nerve. And for the cancerous conditions like CA of pancreas, then your biliary tract CA, your what is that?
Gastric.
Carcinoma. So these are the other stomach carcinoma. Any upper abdominal malignancy, you can go ahead with the celiac plexus block. But celiac plexus block is easier than the splanchnic.
Thank you.
Sir,
Sir, the presence of ascites.
If the patient is having the ascites, then you put one pillow under the chest, another pillow in the waist, and make the abdomen free. In that way, you can. Because, anterior approach, ascites, you cannot go ahead with the anterior approach. Because anterior approach, if the patient is having the ascites, you cannot go with the anterior approach. But it still can go either with the posterior approach. But only thing is, you have to put, depending on the amount of the ascites. If the patient is having a huge ascites, then put 2-3 pillows over the chest and 2-3 pillows over the waist to make the abdomen free. So with the ascites, your only approach is posterior approach. But if the patient is having the no ascites, then you can go ahead with the ultrasound guided anterior approach as well.
Sir, your comment on phenol or alcohol?
Phenol and alcohol both has advantage and disadvantage. Advantage of the alcohol is it is longer duration of action than phenol. But injection of the alcohol is painful. So you have to give the local anesthetic, wait for some time, and then give alcohol. I prefer alcohol because the duration of action is longer. Whereas phenol itself has a local anesthetic-like effect. So you need not give any local anesthetic before injecting the phenol. But the disadvantage is its duration of action is only around 3 months. So the patient's pain relief will be shorter duration. Pain will be recurred earlier. So that is the disadvantage.
Thanks a lot, sir.
So there is a patient of chronic pancreatitis, but having a pacemaker also. So what can be the best treatment for that patient, sir? Whether celiac plexus block with alcohol or splanchnic?
The chronic pancreatitis
Kind of.
patient, celiac plexus block is not a choice, because the patient is going to survive very long. And every 6 months, you cannot do a procedure because it's an invasive procedure. So for the pacemaker, you have to go for the bipolar. So put 2 needles nearby and you go a bipolar. Okay?
So we have to change any configuration in the pacemaker, or we can do
Nothing. You can, you just do a bipolar. Bipolar means the circuit will be completed there. It is not going to go inside the body. So that means it will be very safe for the pacemaker patient. You have to go for the bipolar RF.
At
Sir,
T
should we
level.
rule any bleeding disorders before we puncture the aorta?
Any bleeding disorders, that is the contraindication for any interventional procedure. Any interventional procedures, bleeding disorders, coagulopathy is a contraindication. You cannot go ahead with that. To first correct the bleeding disorders and then only you can go ahead the procedure. Obviously, transaortic, so you cannot think of it. But even if you are not doing the transaortic, even if you are doing the classical or foraminal epidural, bleeding disorders is a contraindication. Remember, there are 2-3 contraindications for all the interventional procedures. One of them is bleeding disorders. Second of them is your infection. If there is a systemic infection or local infection, that is a contraindication. And third contraindication is a very uncontrolled diabetes. But no, renal failure is not a contraindication. Abnormal, liver function test is not a contraindication. But these are the 3 contraindications, remember. One is coagulation abnormality. Second is any infection, local or systemic. And third one is very high blood sugar, uncontrolled blood sugar. Uncontrolled blood sugar is a relative contraindication, not absolute contraindication. But infection and coagulopathy are absolute contraindication.
Thank you, sir.
Your drug of choice for transforaminal blocks, triamcinolone or dexamethasone?
Dexamethasone, if you are doing above the L1, because of the artery of Adam which is there, and because it's the little unsafe. So what we do is in those situation that we are doing the dexamethasone or soluble steroid. In the cervical epidural, thoracic epidural, all are your dexamethasone. But if you are doing below L2, then you can go ahead with the what? Deposteroid.
Thank you.
Anything else from anybody?
Sir,
Yes.
sir,
Yes.
if a patient is on anticoagulant therapy, then for this block, do we follow the ASTRA guideline as we follow for the epidural?
Same guideline. Same guideline for the regional anesthesia. Same guideline. That means if the patient is on 75 milligram aspirin, you can go ahead. But if it is, clopidogrel or 150 milligram aspirin, you have to reduce the dose of the aspirin. And you have to stop the clopidogrel or other stronger things for your 1 week. Why? Because platelet half-life is 1 week. So that means you have to wait for the 1 week, do the procedure, and then again you can start with the anticoagulant therapy.
Okay, okay. Thank you.
Sir, what is your personal preference to SI joint as well as caudal injections with regard to ultrasound and fluoroscopy? Which one to prefer, sir?
For the ultrasound, you can caudal epidural steroid cannot be given only with the ultrasound. Cannot be. That is the standard dictum. Means if we are doing with the caudal epidural, normally what we do in our hospital is the hybrid technique. We puncture the sacrocoaxial ligament and then you have to go enter into, because once you are into the canal, you cannot see the needle tip. Okay. And
True, sir.
then you have to give only in the hiatus. If you have to giving the injection in the hiatus, then what will happen? You have to give a very large volume. So that means for the caudal epidural, you cannot think of doing it under the CR or ultrasound alone. So you have to go for the hybrid technique. I'll be showing you some of the videos there. So we prefer the hybrid technique. I'll be showing you the hybrid technique, this thing. And finally, you have to give the dye to see the dye is not disappearing with the blood vessel. And then only you can go ahead with the caudal epidural steroid with the particular steroid. If you are giving the particular steroid in the blood vessels, patient can land up with a serious complication. And I tell this story to every batch, every time, so that the caudal epidural is not taken lightly. That in Kolkata, what happened? This happened that somebody was doing the caudal epidural and ultimately patient landed up with the quadriplegia. Remember it, quadriplegia, because the particular steroid went through the vessels, blood vessels, and these blood vessels are basically continuous throughout the sacral plexus. So the sacral plexus and all the vertebral body plexus, the anterior epidural space is continuous. So the drug went above and causes the infarction of the spinal artery, and then so this can happen. and similar kind of catastrophe has been reported. So never ever think of giving the caudal epidural steroid, particular steroid particularly, without C-arm guidance. If you are giving the dexamethasone, then you can do it with the C-arm guidance. But if you are giving the triamcinolone, then you have to go ahead. Advantage of the triamcinolone is what? That this is having the longer duration of action. So dexamethasone is having the shorter duration of action. Okay. And for the sacroiliac joint is not that dangerous like the caudal epidural. Sacroiliac joint, you can do both the things. But again, C-arm is the standard. And what we recommend that if the patient is pregnant, in pregnancy, SI joint pain is not uncommon because, the SI joint is basically stressed. So during the pregnancy is your, or any other contraindication for the X-ray or not available, then you can go ahead with the ultrasound guidance. But otherwise, C-arm guidance is a standard technique for both these two procedures. But again,
Sir,
I'll be sharing the video where both ultrasound as well as the C-arm guided the SI joint injection has been demonstrated.
How much volume can we inject in SI joint?
Normally around 2 to 3 cc, not more than that. Facet joint 0.5 cc only. For the SI joint 2 to 3 cc.
Sir, some doctors are using dipomedrol. Is it safe in caudal epidural?
Dipomedrol and the triamcinolone are almost similar. Okay,
sir.
You can use either of them. If you are thinking of doing the particular steroid, then either of that can be used.
Okay, sir.
Sir, can we think of passing the catheter through the caudal space using ultrasound and pass the drug through that so that the entry to the blood vessel can be limited? Any experience on that, sir?
No. Only catheter what is recommended is your RAX catheter. That is a radio-opaque catheter. So through that radio-opaque catheter, you can guide to the desired area. You can go ahead to the sacral hiatus into the lumbar, any desired area, right side, left side. So, but the RAX catheter cost is 20,000. 20,000. So ordinary epidural catheter is not recommended because it is not radio-opaque and you cannot steer your desired level. It's a soft catheter, it will be curling down and you don't have any idea exactly where you are reaching. So that means the ordinary catheter, what is used in the anesthesia practice, is not recommended for the epidural steroid injection. But RAX catheter is definitely recommended. But again, it is limited use because of the cost.
Thanks a lot, sir.
Are you enjoying the classes?
Very much, sir. Very much.
Yes, sir. Yes, sir.
Yes, sir. We enjoy it very much.
Next two will be one is your the ultrasound guided peripheral musculoskeletal, particularly the joint, shoulder joint, knee joint, these are the areas. And the last class will be the ultrasound guided spine procedures, the axial, the epidural and other things that I'll be covering on the last day. And last day also we'll be having a long question answer discussion sessions. Okay, so happy Durga Puja to all of you.
Thank you very much, sir.
Thank you. Same to you, sir. Same to you.
So everywhere is a festive season. But as we told that, I love teaching, So basically, I am also enjoying the Saptami by the way of this class. Thank you all for joining this class. And I am also enjoying like you.
Thank you, sir.
Thank you, sir.
Sir?
Yes.
Something about the C-arm. Hello.
Your voice is breaking. Can you repeat?
Sir, I know something about the C-arm technique. Hello.
Position.
What is your question? What are you asking?
Sir, I am asking. I want to know regarding the C-arm machine.
Means which machine you wish to purchase? Are you asking that?
No, not that. The
what are you asking?
angulation performance of the C-arm machine. How will you use the C-arm machine in the OT? From where the radiation comes and receiving side?
Okay. So, okay, I should have told that, but the assistant has already wrapped up the things. So normally the CM, it's a C, Okay, let me draw it here. Let me draw it here. Where is the... Okay, so CRM is a C, and there is a OT table. So this is the OT table, this is the CM. So CM has a two part. One part is your II. This is called image intensifier. And another is your X-ray tube. So here is the X-ray tube. And this is your table. So X-ray is coming here. X-ray is a point source. It is diverged. And it is being received by the II. And it is... So your patient body is lying here. Okay. So now...
Yes.
X-ray tube should be always, patient normally when you're doing the CM, patient is always in the prone position. Means this is your backside, here is your spine, this is your abdomen. So this view is called AP view. Why? Because from the anterior to the posterior CM beam is coming. So please remain muted. Please remain muted when you are not. Please, according to the disturbance. Okay. So, if the CM is only coming...
Sure. You're at
Please remain muted.
Okay. Sure. Ama. Oh, wonderful. Angu pakkam thalla
Okay. So if the CRM is coming from like this is known as AP view. And AP view is always preferred view. Never keep this above. Why? Because if it is going there, then what will happen? There will be scattered radiation will be coming down. If you are putting it above, what will happen? The scattered radiation will be basically going all around. That means for the radiation safety, you should be always keeping the CRM, means X-ray tube below and II above. And remember, the PA view means if it is coming kept above should not be done in any cost. And the other view will be oblique view or lateral view. Lateral view also gives lots of radiation. So lateral view should be as minimal as possible. You have to go for the lateral view. Without lateral view, you don't understand anything. So you have to check by the lateral view always, but that should be minimal. Maximum procedure should be done in the AP and the oblique view. Okay, is it clear who asked this question? Who asked this question? Hello? Okay, any other questions from anybody?
Sir, what are the minimum investigations which are asked for the in these procedures?
I told you what are the contraindications for the procedure?
Like hemoglobinopathies, coagulopathy.
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 Coagulation disorders.
So PTINR.
Hemoglobinopathy is not a contraindication. Suppose somebody is having the hemoglobinopathy, that is not a contraindication. Coagulopathy, bleeding disorder is a contraindication.
Bleeding disorders.
That means the basic minimum investigations to be done always. One is your coagulation profile. Another is your routine blood and ESR CRP to rule out the infection. If your total count is higher along with ESR and CRP raised, so that indicates the infection, systemic infection. So that means what are the investigations to be done? One is your routine blood with ESR CRP, coagulation profile, and the blood sugar level. As I told, blood sugar is a relative contraindication, not the absolute contraindication. So these are the things you have to do always. If you're asking, should you go for the LFT, liver function test, kidney function test, all other things, as I told you, these are not the contraindication. That means in presence of renal failure, surgery might be contraindicated, but intervention is not contraindicated. In presence of the liver failure, the surgery might be contraindicated. So that means those investigations are optional. You may or may not do it. But what is mandatory? Routine blood, ESR, CRP, and coagulation profile.
Thank you, sir.
Okay. Okay, so good night for today.
Thank
And
you,
happy
sir.
Durga Puja to all of you. And
Thank
meeting
Thank you, sir.
again next week.
Happy Puja.
Next week
Okay,
we'll be coming
sir.
up with the musculoskeletal ultrasound with the
Thank you,
peripheral
sir.
musculoskeletal ultrasound.
Thank you. Thank you, sir.
Thank you,
Thank
sir.
you, sir, and
Thank you.
happy Durga Puja, sir.
Happy Puja, sir.